Recording in progress.
A very good evening, everyone. I welcome you all for the APFSSH, APFSHT, APWA Pre-Congress Webinar Series 2025 organized by SSH. Now I invite Dr. Nilesh sir to welcome the speakers and moderators. Over to you, sir.
Thank you, Shweta. A very warm welcome to all the delegates. It's now 6 months that we have started this webinar series, and we have had one of the best speakers in all the webinars. And today also we have stalwarts from 3 different countries who are masters in their field and are leaders in their country. And we have equally dynamic moderators today with us, Professor Anil Bhat from Manipal and Dr. Bipin Ghanghurde from Mumbai. I hand over the session to the moderators to introduce the speakers and conduct the session. Thank you so much.
So good evening, everyone. Good evening here in India. And welcome to this 6th webinar series, or it's a pre-Congress academic effort done by the organizing committee from the ISSH, which is hosting the APFSSH, APFSHT, and Upper Congress 2025 at Mumbai in September. So this series has been really, kind of very interesting and very kind of teasers for our upcoming conference. And I see Dr. P.C. Ho. So welcome to this webinar. It's good to see you. And there is Shilu from Nepal. Welcome, Shilu. And Emmanuel, Estrella from Philippines. So we have 3 good speakers here with us and who would enlighten us with a variety of ranging from Hemihamate going towards the hand reconstruction and thumb reconstruction. So we'll start off with Emmanuel Estrella from Philippines. Is that the order, Nilesh?
Yes.
Yeah. For the ever fascinating Hemihamate arthroplasty, which I think the younger hand surgeons dream of doing it. The moment they start their practice, they want to do one Hemihamate immediately. So that's always probably a fantasy kind of a thing. So Emmanuel, it's all yours for the floor.
Okay, thank you. I'll share my slide. Okay, so thank you, everyone. I'm happy to see old friends here, Shilu and Nilesh and PC Ho. And I'd like to congratulate in advance all the organizers for putting this webinar. So for today, I'll be discussing the Hemihamate arthroplasty for PIPJ fracture dislocations. Okay. So I have no disclosures. Let's start off with a case study. This is a 25-year-old male, a right-handed executive with a 3-week history of a finger jam from basketball, the middle finger involved. There was swelling and pain on the middle finger, and this X-ray showed a dorsal fracture dislocations involving around 40 to 45% of the volar lip. And what should we do? Now, to start off, the fracture dislocations of the PIPJ, this was classification was introduced by Hastings and Carroll in 1988. Stability is mainly determined by the size of the volar fragment. When 30% or less of the articular surface is disrupted, the injury is likely to be stable. If it's 30 to 50%, injuries exhibit a tenuous stability, and injuries that involve more than 50% of the time are unstable. although these numbers are useful guidelines, the stability is always be assessed clinically at the time of the treatment. Now, the key concept for this is the congruent reduction. Now, the treatment for the tenuous and unstable fracture dislocations are basically very difficult and controversial. There are a lot of treatment modalities being proposed and has been published throughout the years. This would include extension block techniques reported as early as 1972, transarticular pins, traction methods, static and dynamic external fixators, percutaneous or open reduction internal fixations, either with mini screws or mini plates, volar plate arthroplasties, and our topic for today, hemihamate arthroplasties. Now, the hemihamate arthroplasty, this was introduced by Hastings in the 54th ASSH meeting in 1999. Now, because of the similarity of the contour of the partial hamate with the base of the proximal phalanx, of the middle phalanx, it aims to replace the damaged volar lip to provide stability. Now, the indications and contraindications would include a large unstable volar lip, usually of more than 40%, fractures that are not amenable to open reduction internal fixation, failed initial procedures such as traction, extension block techniques, or volar plate arthroplasties, and the like. Now, contraindications would include damaged dorsal cortex of the base of the middle phalanx and arthritis of the PIPJ. Now, for preoperative planning, the range of motion should be recorded as tolerated, especially if this is of chronic and delayed nature. The assessment of the lateral deviation should be done because this represents asymmetrical compression of the base. Standard radiographs would include the AP, oblique, and lateral views. CT scan can help assess articular comminution but is rarely indicated. Now, the assessment of the size of the defect is usually finalized during surgery. Now, in terms of surgical technique, initially, before doing the approach, a fluoroscopic evaluation on the instability of the PIPJ should be attempted, and a classic V sign or the hinging of the base over the proximal phalanx head is usually seen, such as the one shown in this picture. Now, in regards to the exposure, usually the palmar V or Brunner incision, but I prefer what we call a lazy U. Now, once we have done the skin incision, we will open up the pulley with the base on the opposite side and create a flap between the A2 and the A4 pulleys. Now, after that, we will release the volar plate distally and release the volar plate from the collateral ligaments on both sides of the PIPJ, thus exposing the PIPJ. Now, once this is exposed, we will do what we call the shotgun maneuver by doing an hyperextension of the PIPJ. Here, we will be able to assess the size of the volar lip fragment, its comminution, and the dorsal cortex, if it's intact or not. Now, several questions that we ask ourselves are, can it be fixed, or is the fragment large enough for internal fixation? Along with this, we should assess the cartilage status of both the proximal phalangeal head and the remaining middle phalangeal base. Now, any fragments on the anterior lip of the base of the middle phalanx should be elevated and excised, especially those that are impacted fragments. Now, in preparation for the fracture site, you can use a mini oscillating saw or a small rondure. You can see here on the right are two pictures on how we can prepare the fracture site. A is typically good, which straight cut, which works most of the time. But if the graft turns out to be small or the obliquity is not what you wanted, then we will have a hard time recreating the concavity. because the basis for this reconstructive surgery and the key for this reconstruction is creating that concavity of the joint. Now, the picture below, wherein what I try to do in most cases, I try to make the cut aiming volarly and distally, and this gives me room to shape the graft. Now, a step is also created distally to prevent any distal migration of the graft once it's fixed. Now, the graft dimension is now measured, which will be the basis in harvesting the graft from the hamate. Now, this is a picture of once we will have a longitudinal incision or a transverse incision on the hamate, and then the measurement that we have done will be applied. Now, the challenges of the current antegrade hemihamate harvesting would include creating a proximal trough in the hamate, which is required as a starting point for the osteotome. However, when we do cut the graft, the articular surface is determined blindly, and therefore the proper size is difficult to judge. So, an article by De Noble and the record helps us create an easier way or modifying in order to harvest it. Because if we harvest it in the wrong way, then we will have to shape the graft and we will have difficulty in creating that contour. Now, the article discussed a portion of the fourth and fifth metacarpal base is then removed in order to achieve a good harvest for the hamate or the hemihamate. So the shape of the graft allows for proper orientation to the middle phalanx joint surface, and the excess of the graft can be removed with a saddle. So once the graft is fixed. Now for graft fixation, we should tailor the graft again to create the concavity of the surface of the base. We can use a K-wire, place it centrally on the graft to serve as a guide, and then place 2 or 3 screws. Usually we use a small mini screw, 1.0 or 1.5 millimeter. A large graft is okay. Usually it's large, at least in my experience, we create a large graft in most cases. And after this, we reduce the joint and then assess the stability by going through the full range of motion. Now, you can see here on the X-ray, there seems like a step off, but again, we all know that the cartilage of the hamate is thicker than the PIPJ, such that on radiographs, this will appear to be a step off. So again, with the X-ray, we created a concavity on the base, which will add to the stability of the PIPJ. Now, after this, once we've assessed that the PIPJ is stable in its full range of motion, the flap that we've created, we will interpose this between the PIPJ and the flexor tendons, and then we will repair the collateral ligament to its stump. Some do advocate reattaching the volar plate, especially if there's a residual dorsal subluxation, because repairing the volar plate will add to the stability and prevent dorsal subluxation of the joint. Now, the finger will be placed in a dorsal blocking spin around 20 to 30 degrees of PIPJ flexion, and range of motion can be started as early as 1 week. Now, if you do have recurrent subluxations, probably in most instances, failure to achieve a concave middle phalangeal base was achieved, and the inadequate anterior support will contribute to this subluxation. Now, if this occurs, again, the relevance of repairing the palmar plate or the volar plate may prevent this dorsal subluxation. Now, in most cases, there will be a PIPJ flexion contracture of around 10 to 15 degrees, and the range of motion post-operatively averaged around 85 degrees. Now, there was a paper systematic review published in 2020 by Ginakos and John Capo, and then they reviewed fracture dislocations of the PIPJ and several treatments, including hemihamate arthroplasty, close reduction with K-wire pinning, dynamic external fixation, or if extension block pinning and volar plate arthroplasty. Well, the findings that they had that the hemihamate arthroplasty fared very well, especially in the range of motion and the dash scores. Also, secondary procedures were not as high compared to open reduction internal fixation, and they had no subluxation. However, the incidence of osteoarthritis was around 26%, which is lower than the extension block pinning. Now, we had our own case series of 5 patients, all males with a mean age of 32 years old, middle finger involved in all cases except for one, with a mean delay of 2.6 months. The mean involvement of the joint of the anterior lip was 56%, and the mean follow-up for the 5 patients was 30 months. We had an extension lag quite big, around 29 degrees, with a range of 10 to 30 degrees. Now, the mean arc of motion was 92 degrees. We had one subluxation, but the mean range for that patient was 70 degrees for the PIPJ. In this short, small series, we had a chronic case of 6 months for post-injury. The PIPJ was ankylosed upon presentation, and from the X-ray, we surmised that the joint more than 50% was involved. So our plan then, after talking to the patient, was we can either do an outright fusion or we can check if this is possible for hemihamate arthroplasty. Intraoperatively, we noted a 60% involvement. You can see here the cartilage degeneration. It's not normal, but since it's not completely denuded, we proceeded with the hemihamate arthroplasty. 15 months on follow-up, patient had no complaints, no pain. However, he had a 25-degree flexion contracture with a good range of motion of 100 degrees. Now, in our case study, we did a hemihamate arthroplasty using 2 1.5 millimeter screws. Range of motion was started within 2 weeks. And 32 months follow-up, he had quite a good range of motion, 100 degrees, with only 10 degrees PIPJ contracture. At the time, the involvement was 40% for the joint. So you can see here a very good motion for this patient. Not all will have this motion, but we were fortunate for this patient. Now, in summary, the hemihamate arthroplasty should be considered in PIPJ difficult fracture dislocations, especially if the joint involvement is more than 50%, where open reduction internal fixation cannot be done. Also, these are indicated in lesser degree of involvement of the joint, but with persistent PIPJ instability. Also, they can be used in chronic cases, such as in our case, and in young patients. Now, to end this presentation, I'd like to quote Dr. Alfred Swanson, that hand fractures can be complicated by deformity from no treatment, stiffness from over-treatment, and both deformity and stiffness from poor treatment. And with that, thank you for listening. Thank you very much.
Thank you so much, Emmanuel, for that comprehensive coverage of the hemihamate arthroplasty. And I think that last line of responses will always be very much relevant for this particular procedure when the techniques are not followed and the specifications of the procedure are not really adhered to. And it's not just putting a graph there and then presuming that it will work.
So there are no more questions now. I have one question here. Dr. Emmanuel, excellent presentation. I want to ask you which fingers do really good with hemihamate arthroplasty, because you know the condylar shape changes as you go from index to the little finger. So do you have any experience with that? Do you shape the graph likewise?
Well, because the most common is probably the longest finger for finger jump, the middle finger. I think it fits perfectly the hemihamate especially if it's the involvement is more than, again, 50%. So probably in the smaller finger, it will be more difficult. But I think for the ring and because in literature, one of the studies, larger studies, had the ring finger as its most common involved. But in our experience, even with not using hemihamate arthroplasty or if or just extension block pinning, the middle finger is the most common involved finger. But I think the hamate will fit perfectly with the middle and ring fingers.
Middle and ring. So do you contour your if you have an index, because index is little tricky and the little.
Yes.
So what do you do anything special or it's the same? You turn the graft a bit or something like that?
Oh, okay. The probably the I think the key here for the reconstruction is maintaining the contour, the concavity, regardless if the articular surface is congruent or not. Once we've maintained the congruity or the articular congruity, then dislocation will be minimized. And I think that's more important, that we create that concavity, regardless of how we orient the graft.
Okay, thank you.
Dr. Emmanuel, I have two questions. One is, we see people doing this for acute and chronic. I mean, I've seen people doing it even for very early injuries, which probably could have been managed with some other methods. So in your experience, what is it? Is like how soon or how late, and what are the results? Is there a difference?
Okay. I think one of the key features in considering this method is number one, the degree of joint involvement. Now, if the joint, the anterior lip is big, that can accommodate a screw or a mini plate, I would prefer that than the hemihamate arthroplasty. However, like in our index case, the X-ray showed it looks like a large fragment, but intraoperatively it was depressed and it was comminuted and it was impacted. So I guess the final decision will be done during operation. It can be done as a primary procedure for acute cases and in cases also for chronic cases, such as the one I presented, 6 months, with some degree of cartilage degeneration, but still more than a year on, has no complaints. And I think it can be used as a primary procedure or a salvage procedure if the other methods have failed, or in chronic procedures also.
Thank you. I think Dr. PCO has a question.
Yeah, thank you very much, Emmanuel. My question, two questions. First of all, is how do you stabilize the fragment? I mean, how do you stabilize the joint? Do you routinely repair the volar plate or just repair it when it was still unstable after you put in the graft? And the second question, or maybe you answer the first question. Thank you. Yes.
Okay, thank you, PC. Okay, so I had that statement with an asterisk on one of the slides. So in most texts, they recommend repairing the volar plate, but usually we at least for me, I harvest a big graft. It's very difficult to harvest an exact graft that is similar to the anterior lip of the base of the middle phalanx. So I think a big graft is okay. It's not bad. It will prevent dorsal subluxation. If I can, I think one of the pitfalls of repairing a volar plate with a big graft is that it can produce the flexion contracture more readily than by not repairing it.
So overstuffing will be enough. Overstuffing the graft will be enough to provide the stability.
I think so, yes.
Right.
Because when you shape that graft, you can see over the years the graft has remodeled in size. And I think one of the key indications for the repair of the volar plate is if produces subluxation intra-op or before you.
Thank you. My second question, I'm a risk lover. I always worry about the donor side morbidity. In fact, there are very few people mentioned about what happened to the handmade site. What is your experience? Do you experience any adversity at the donor site?
For me, I think in one case, I was so afraid that the fourth and fifth will collapse because I think I harvested a big graft, but they do well. I pinned that, but the others I did not pin anymore, and they do well. It's asymptomatic. None of them complain. Even those 5 patients are those with long follow-ups, but with those with shorter follow-ups, they don't complain. Although it looks scary that you've harvested a graft with that.
Yeah,
there's an article that they stuff it with artificial bone graft or bone graft, but I think in most cases it's not needed.
So maybe the fourth and the fifth CMCJ is quite accommodating, so that the morbidity is so common. Thank you very much for confirmation. Thank you.
Dr. Shilu, please.
Yeah.
Thank you so much, Dr. Estrella, for your wonderful talk. I just have one question. The case you showed, like 6 months old, did you ever had to put kind of a distraction fixator like Suzuki frame in case of older cases like in 6 months old fractures?
Okay, so I found that in that case that the key step is releasing the collateral ligaments. It was because it was ankylosed when it presented, and the fracture has healed already. But when we release the volar plate and the collateral ligaments, I think almost all of the collateral ligaments distally we have elevated. So that was the key, that we were able to do a shotgun procedure for that hyperextension. So I think one of the key is releasing the collateral ligaments early on, just routine release, so that you won't have trouble distracting it or hyperflexing the PIPJ.
Thank you.
My second question again was what Dr. PC was interested, the donor side morbidity, actually, especially the new technique which you showed. I mean, the one publication, I think, is shooting off at the base of the metacarpal and then coming towards the hamate. I think that would even cause much more instability and just taking the hamate graft. What do you think? Is that a wise way to do it?
I've also seen an article, and we've done it once or twice, I think. We tried to push the fourth and fifth and insert an osteotome instead of including the dorsal part of the fourth and fifth base. If that can be done, then we can minimize that getting that part. I think partial osteotomy of the fourth and fifth. I mean, the cases I've done not so much, but probably in the future we can see some complications if this has been done more frequently.
I guess a good dorsal capsular repair, I think, is very important to minimize any of those things. Right. Thank you so much, Dr. Emmanuel. I think that was wonderful. Bipin, would you like to introduce Dr. PC Ho?
Yeah. So the next speaker is Dr. PC Ho. So Dr. PC Ho, as everyone knows, is a very esteemed hand surgeon from Hong Kong, and he'll speak on tissue augmentation in extra thumb reconstruction. Over to you, Dr. PC.
Thank you very much. Good evening, everyone. We are 6:30, 7 o'clock in the Hong Kong side, so many of now is an evening time. So I know, thank you very much for the very kind invitation. First time to join this very meaningful webinar to share our knowledge and experience. Most of people know me about on the wrist, but in fact, I also love many aspects in hand surgery. One of my aspects I love a lot is the congenital hand. And in fact, in Hong Kong, we did quite a lot of congenital hand surgery. So today I speak a little bit different from my usual topic. It's about the extra thumb reconstruction. I'm sure in many places in Asia, we have faced the same big population of extra thumb. So, the congenital duplicate thumb, there are many terms about that. So basically, most of the time we see the duplicate thumb, they are not the same on its own, except the very rudimentary type like what we see in the picture. So this is something very simple to treat, but in fact, this is not the majority. Majority are actually like a two different thumbs built on the same root. So often when you really treat the duplicated thumb surgically, tissue combination or to augment the retained thumb is often a natural choice, or sometimes it's the only choice to build the best possible thumb and without sacrificing other body parts. So we have to make a very careful decision making often at the time of surgical planning. So in fact, back to the basic principle is how we can make an ideal thumb. What are the parameters that we tend to use? When we look at this point, I think we have to look at several aspects from the structure point of view, from the function requirement of the thumb, and also from the growth aspect. Particularly, we are dealing with very young kids. So there are different parameters in terms of the structure. Generally speaking, when we talk about the size of the thumb, our aim is to actually get the thumb shouldn't be as too small. So often the width of the nail is often a very good direct parameter for us to assess the size of the thumb. And usually more than 70% of the width of the nail is what is desirable. The symmetry, we have to look at the symmetry of the pop, the nail, and the nail fold. Hopefully they can get a symmetrical alignment. The length, normally the thumb should be able to reach the index finger PIPJ level. Alignment, of course, we have to look at the several parameters, the sagittal plane, coronal plane, and axial plane. The position in space, whether it's in an appropriate abduction and in the opposition direction. And finally, the web space is very important. At least in the metacarpal angle should reach about 45 to 55 degrees in the kids. So in terms of the function, again, several parameters, we have to look at the kids, whether the joint are stable, and in particular, we know the ulnar collateral ligament is always take priority compared to the radial collateral ligament in the thumb. The mobility is important, and we know that in order of importance, the CMCJs, perhaps the most important, and I will rate the IPJ the next important, and followed by the MCPJ. The sensibility, of course, has to be retained, in particular, outer aspect is for the pinching and the gripping side. All the thumbs should maintain good vascularity, and the strength has to maintain by adequate muscle and also intrinsic and extrinsic muscle. And last but not the least, the growth potential has to be respected. Any surgical intervention must not damage the growth potential. We should aim for normal growth and without any angular deformity potential. So Dr. Graham Lister actually has taught us about the principle of thumb reconstruction. This is applied to all ages, perhaps. And actually lists out the relative importance of the relative parameter. He thinks that the position of the thumb is actually maybe the number one importance, followed by stability of joint, strength, and length, motion, sensibility. And actually, he put appearance quite low. I'm not too sure, but I think most of the parameter, I think probably we agree, but I think the importance of the appearance may be underemphasized. I think, in fact, particularly in the generation of the kids, I think the appearance is very important, particularly from the parent point of view. So like in this thumb, it's actually still a very functional thumb with an adequate length, size, and motion, but is the patient really happy with this? Of course, the patient is not very happy. Even should the patient would like to take the toe from the big toe in order to get a better thumb. And because if you can be able to get a thumb like this, I think it's much happier. So I think we also have to respect the appearance, the psychological impact, and the social aspect of the hand and the digit for the patient. So therefore, when we talk about back to the extra thumb reconstruction aspect, we have to really look at the different structural and functional characteristics of each thumb. So when we assess each thumb, we have to assess each of these structurally and functionally, and try to look at the deficient area. What have been deficient? Is the motion deficient? Is the stability deficient? And determine the target of reconstruction. And of course, try to get the best possible. It's always not possible to get a perfect solution, but try to guess what should be the target reconstruction. And always important to consider, if we are going to ablate one digit, whether that ablated digit can still contribute some spare parts for the improvement of the retained digit. And all the time, we have to balance the risk of reconstruction versus simple ablation, okay? Because although we can achieve some purpose, but they also put the risk excessive high for the kids. And overall, we talk about the surgical planning and execution. So what's the problem if we think about too much reconstruction option, okay? Of course, there may be excessive scar or cosmetic problem. Fibrosis may set in. You may actually impair the growth potential because too much surgery around the kids. You may actually induce ischemic problem if you damage to the vascularity, nerve injury, tendon muscle injury, joint incongruity, and premetamorphosis. And don't forget that excessive surgery will actually increase operating time. And we understand that for kids under 3 years of age, the potential risk on the anesthesia for long anesthetic time over 3 hours. So I think often we may counsel the parent we have to also put it into consideration. So many of the extra thumb can actually be achieved by relatively simple reconstruction. Like this is what we classify as a 4B. Usually they have one major dominant thumb, usually on the outer side, and a smaller one. That is relatively easy because obviously the retained target must be the bigger outer digit. And what we need to do is to actually try to correct the alignment at the MCPJ, either to reposition the joint, or sometimes if the joint is too oblique, we have to do an oblique osteotomy. And most of the time, the soft tissue reconstruction is mainly to focus on the radial side, meaning the collateral ligament and the small muscle. Like in this case, when we at the end, when we ablate the digit, we have to always retain the collateral ligament on the radial side, and also to detach the APB muscle and then reattach again. So at the end, we would be able to achieve a very nice looking thumb. The most famous reconstruction procedure must be the classical Bipin procedure, which has been first described by 1890 by Bhat, mainly for the Warsaw type 1, and later on it's been extended to maximal proximal Warsaw type. The ideal indication is when both thumbs are small and symmetrical, and they probably have the equal share of the interphalangeal joint, and both thumbs are small at the same or at a similar level, and they have an equal nail length and the linear position. In this case, it's a relative ideal condition, indication for biocorporate operation. And most of us will do a dorsal incision, try to centrally retract the central wedge, may trim the condyle to make the phalangeal a bit better looking, and then combine the structure in the same structure, like including bone, joint, and nail bed, etc. So like in this case, this is a type 2, actually it's a kind of a type 2 or 3 extra thumb. So you can see we try to apply this principle and remove the central wedge and combine the bone and also the joint together. At the first of it looked like quite a nice operation. Actually, the thumb looks very nice and symmetrical. But with time, actually, very often you will see this problem. The nail ridge comes to see, and there's also a big major scar over the dorsum, which may not be very happy for the parent. And of course, at 3 years age, the kid is okay, but I mean, most of the time is the parent under stress. So we did see a lot of so-called poor outcome of BC procedure because they're mandatory. The scar has to be in the central dorsal, which is the most cosmetic part of the hand. And also the nail ridging problem is always quite common. And sometimes the special challenge when it comes to those even less ideal situation, like for example, neither digit has an adequate size or ideal shape, like this case, or digits basically are not symmetrical, or actually the digits are of different length. So when the digits are of different length, basically it's very difficult to do the biocorporate procedure because we actually require the similar volume of the tissue to combine together. So under this situation, is that we don't have a method to try to make the best reconstruction of thumb. So how to improve the cosmetic outcome? My point is how to restore the pop and the nail symmetry, to restore the size discrepancy, and at the same time, ideally, if you can avoid the dorsal scar, the kid will be happy. So over the year, we actually found that when we excise usually the radial digit, often we can see a very discrete single neuromuscular bundle supplied to the radial digit. Actually, at one time, I think that maybe we can utilize this neuromuscular bundle to use it as a pedicle for a tissue from part of the ablated digit. And using some microsurgical principle, you can actually achieve a good reconstruction to augment those tissue which is deficient on the retained digit. So this is what we developed as the onychocutaneous neuromuscular island flap. So this flap will including the skin, the pulp, and also the nail, and with or without the bone. So this is something, the concept that we want to put forward for today. So this onychocutaneous neuromuscular island flap has an advantage because if we can utilize this concept, because the pedicle is relatively flexible and versatile, the thumb need not to be at the same level. And with this design, we can also avoid the central scar, and therefore we can minimize the dorsal scar, and also we can allow to combine different tissue with one pedicle, depending on the deficient on the retained digit. But just like any surgical method, there are also excessive, sometimes some risk become from not all the case as that vascular pedicle. Sometimes we find an absent of pedicle. And of course, when we do the surgical undertaking, we have to be very careful because if we compromise the vascular supply, the tissue will be lost. So, and most importantly, when you perform this surgery, we definitely increase the operating time. It's a very fine surgery. So I started to have this idea in 2002. So now we've been doing this surgery for more than 20 years. And this is a series is my initial 14 patients, which including 2 girls and 12 boys. Most of them are type 4 and type 5. And there are 2 bilateral cases. And we operate at every age of 1 year old. My indication is when the thumb has very asymmetrical nail fold or pot, or there's a significant discrepancy of the nail width or circumference. Typically, it is less than 70% of the contractual normal thumb in terms of the width of the nail. Or if both sides are abnormal, like a both side bilateral axial thumb, if the thumb is smaller than the ipsilateral index finger, I think that will be indication to augment or combine the thumb together. And last but not least, the patient has to be accepted additional risk of surgery. So I can tell them that it is possible to increase the size and also improve the appearance, but at the risk you have to do a longer surgery. So this is a typical case example of type 3 extra thumb. This case, you notice that actually both thumbs are small. They are not in the same level of the location. And the nail pop is also not symmetrical. Typically, when you have this convergent type, the pop tissue in the middle will be quite thin and hyperplastic. So if we just retain one thumb, the appearance will perhaps persist in lifetime. So these are basically design. Usually, I like a dorsally based flap design, which is applied to every case. I think when we apply this concept, the resulting scar will be basically just lying slightly folded to the mid-axial line, which I think is cosmetically more pleasant. So this is the basic design, dorsal base flap. I also already marked out the size of the flap, which we intend to combine with each other. So with the major incision, I open up. This incision allows you to expose the entire thumb abnormality at the MCPJ level. So therefore, we can actually do all the necessary work like the reconstruction of the collateral ligament, the abductor muscle, or even you can perform osteotomy at the proximal at the metacarpal if you think it's necessary. And at this dissection, we have to dissect the pop from the radial digit and carefully preserving the single neovascular bundle in the one pedicle. And this is important at this time, very important not to create any additional incision on the retained digit first. You have to test the vitality of this pop tissue. So I will turn off the tourniquets, and only when you fulfill 2 conditions. One is when the circulation of flap is perfect, and secondly, when you act together side to side, you think the appearance is good, then you go ahead for your subsequent surgery. But in case in the rare occasion that actually after the tourniquet off, the flap is still not so vascular, I think definitely you should not proceed for surgery, and you should aim for simple reconstruction rather than this relatively complicated reconstruction. So with this on, we excise the excessive tissue from the ulnar digit. And then afterwards, this is the most important part. When we combine together, we use the best possible method. I always use under the microscope, I use tenovical, very small, very fine absorbable stitches to put the suture, the nail bed together without tension. And this is at the end of the surgery, you can see we can reconstruct the pop, restore the symmetry and the nail smoothness. And I use some of the skin dermabond to glue the nail plate together so to protect the repaired nail bed. So this is at the end of the day, you can see the surgical scar is aimed to produce slightly more on the polar side, so that from the dorsal aspect, the only scar appear will be the small oblique scar at the end of the pop. So this is 6 years, 5 months of the surgery. You can see this patient got a quite nice reconstruction. You get the both sides quite symmetrical. This is 10 years, 7 months follow-up. You can see continue the nail continue to do well. The patient is very happy, and compared to this original appearance, is a much improvement. There's another case. You can see this is too small thumb on the end of the proximal phalanx, and each of them are small and asymmetrical. So when you're doing the surgical planning, we can carefully measure the width of the nail of the opposite normal thumb. And then we try to find a place we can actually match the same length of the nail. This is important. If you cannot locate 2 parts of the nail which are provided the same length, it's impossible to combine together, because it inevitably will produce quite ugly nail appearance. And at this location, when we combine, we can actually calculate is around 8.5 millimeter in nail width. So with this, we proceed for the same surgery. And again, it's very important, microsurgical repair of the nail bed. Make sure that hyponucleum, the nanula, and the epinucleum has to be at the same level. When these three strategic points is at the same level, the nail bed can be quite nicely reconstructed. So this is at the end of surgery. This is 17 weeks after surgery. And this is 7 years after the surgery. You can see the symmetry of the nail, the width of the nail is very comparable. This is actually my second case done in 2004. You can see it's a difficult case, a typical type 3 with a radial deviation deformity after do the opening osteotomy in order to correct the bone alignment and also some soft tissue reconstruction at the end. This is 6 months after surgery, quite nice, quite smooth nail. And this is 16 years, quite a long-term follow-up. You can see that both sides, again, achieve the equal width. And there's only a very little ridge, I think, was very acceptable. But the kids are very happy about this appearance after 16 years. So this is case 3, done in 2006. Difficulty is actually the two thumb has a very big discrepancy in the length. And also is atypical because it's the ulnar digits which is more abnormal. So in this case, I decided to use the ulnar digit to augment the radial digits from the ulnar aspect, create this island flap, and combine together. You can see again a very little scar as seen in the dorsal side. This is 6 months after surgery, 2 years. Again achieve the same width of the opposite thumb. And this 12 years after surgery against such a little bit minor abnormality, but it's very acceptable and very little scar seen on the dorsal side. And finally, this is maybe the most difficult case. Both of them very small, and then you have to choose the appropriate part of the thumb to combine together. And in this case, against other type of the complicated procedure also need to be combined together. And in this case, also combine the bone. You can see the bone was putting side to side, and this is the outcome at 14 months. And this is 4 months. Not the perfect, but I think it's quite achieved quite symmetry to the other thumb. And it's a big difference compared to when the child was at birth. So we followed the patient for about 8 years, which is pretty long-term follow-up. 13 cases achieved full successful procedure. 1 case is ischemia. So I gave up, and therefore I do not touch on the other side. So unfortunately, I do not harm the outer digit, but it will be forever a little bit small and a little bit deviated. There are no complication. All patients certified with outcome. The mean satisfaction rate is 78%. So in terms of the functional and satisfaction outcome, we use a Tartar score and a JSX score. They are actually pretty good looking at the overall outcome. The nail width before the operation is a 19% discrepancy. After operation, it's only 1.9%. So actually, it's pretty close to the normal thumb appearance. The circumference difference is only 3.8 at the end follow-up, so actually pretty similar. And the nail ridging, which we are concerned, most of cases are inconspicuous. 1 case has a 1 millimeter ridge. The 3 cases actually the ridge is a bit prominent. So we cannot guarantee for the parent that our surgery will always obtain perfect outcome, but we have to tell them there may be some undesirable case, but most of them they are satisfactory. So in fact, we decide aesthetic score using the size, the shape, the surgical scar, the smoothness of the nail, the symmetry, and then decide this score system. And the maximum point is 18 points. And in our study is 13 out of 18 as average score, which is actually correlate with the patient's, the parent's satisfaction. So we think actually from parent point of view, they're more important look at the appearance of the child rather than the absolute function of the child. So therefore, we should respect the aesthetic aspect of the kids. So you are interested, you can actually take a look at our published publication, and we confirm that this is actually pretty good solution for a difficult case like this. Sometimes this flap can also be applied in different applications. Like this case is a type 6 extra thumb, and this patient has a very tight palmar skin and also very narrow first web. So in this situation, it is possible that actually when we ablate the radial digit, we can using this vascular island flap to not this time to augment the pupil, in fact to augment the palmar skin. So using this palmar skin, you can use the same type of skin to augment the palmar skin, because in this case, the tightness is actually due to the palmar skin deficiency. Another augmentation we can perform is the collateral instability, because you can see the patient has a very major instability. But using the ablated digit, we can actually harvest the autograft from those of the ablated digit and use it as a graft to graft the collateral ligament over the MCPJ and also the CMCJ. In this sense, we can actually have a better joint stability. So this is at the end of the procedure. And this is 4E. You can see that with this reconstruction of the collateral ligament, we can also achieve very stable CMCJ, MCPJ. And the first breath is very satisfactory. The skin is actually durable. So this is another application of this island flap from the ablated digit. So last but not least, one of the reconstruction is when both thumb is very abnormal, like this type 6, both thumb are very abnormal. It's very hard to retain just one digit. Then it's actually possible to perform an orthoplasty, meaning that actually choosing the better thumb part from one thumb and then to augment the deficient part of the other thumb. So in this situation, is a typical situation of duplicate hypoplastic from both sides are hypoplastic. So we're actually using the good quality to combine each other. The goal is to retain a larger thumb as the ultimate functional thumb and create a good web space. And we have to transpose the good distal component of one thumb to the good proximal component of the other thumb. We have to create the first web space using a transposition flap. You have to create the best stability of the MCPJ and also the CMCJ, and sometimes to address the IPJ stability and also manage adductor muscle strength. And you have to watch out to preserve the blood supply, to protect the digital nerve, to preserve the tendon, to preserve the growth potential, and avoid fascial injury. So this is a case that actually I did together with my mentor, Professor Hong. Actually, this case, you can see that this thumb has the type 6. The radial thumb is better on the distal component, but the ulnar component is very poor, is triphalangeal. And also the MCPJ is actually better on the ulnar digit. So in this case, we decide to transpose the radial digit to the ulnar digit while to ablate the poor distal component. And using this transposition flap and digit, you can actually place it into the better position. And this is a very long term for 21 years. You can see it on the right, left-hand side is a pretty nice looking thumb. Achieve the purpose we can want to achieve is try to retain the maximum appearance and also the function of thumb. And using this digital transposition, it is possible to achieve this purpose. So in conclusion, I think the tissue combination augmentation is a very useful concept and often applicable in extra thumb reconstruction. We have to always bear in mind this is one of the options for the patient. Of course, the principle is you have to understand what is the structural, the functional, and the growth requirement for the thumb. And we have to identify the deficient and all the potential deficient area of the reconstruction and try to set up a realistic target of reconstruction. Best use of the share part from the ablated digit, and careful balance between the risk and the benefit. And finally, you need a good planning and also execution of surgery. So ladies and gentlemen, I want to also invite you, being a risk lover once again, I want to invite you to the year end. We have an annual risk approach workshop in Hong Kong. You're all always welcome to join us. So hope to see you in Hong Kong. Thank you very much.
Thank you. Thank you, Dr. Ho, for this excellent presentation. The extra thumb is always a problem aesthetically, which you have shown very well. I always had this question in mind. Whenever we ablate the extra thumb, which we are using, there is always a joint there. How do you deal with that joint? There's an extra joint as well, especially in type 6. So how do you deal with that joint, which is formed due to the extra thumb?
Right. So, for example, you talk about type 6. Okay, so they are five at the CMCJ level. Okay?
Yes.
So, sometimes you ablate the extra digit, the trapezium may appear to be a bit too big. Then, of course, you can match the size of the remaining outer digit to the trapezium, and then shape the bone or to trim the bone accordingly, while at the same time try to reconstruct the radial collateral ligament. But of course, as I show you, the type 6 extra thumb is usually a lot of abnormality at all levels. So they have a problem at the CMC level, also at the MCPJ level, and also even at the IPJ level. So therefore, each case is a little bit different. But generally speaking, for the joint, usually when you, for example, the most common type 4 extra thumb, they usually both proximal fillet will share one single metacarpal head. So in this case, after you ablate the radial digit, usually the metacarpal head is too big, and then you just need to trim the condyle. Occasionally, the both because the two major types, one type is one roundish metacarpal head and share two metacarpal. Usually, after you remove the radial digit, you can realign the collateral ligament so that the outlet digit can be realigned properly. On the other hand, there are other types. There are actually two facets over the combined share metacarpal. In this case, even you take away one digit, the remaining digit is still deviated outwardly. In this case, you need to do an oblique osteotomy in order to bring the outward angulated facet into the proper position. So again, it's actually quite individualized. Decision is also depending on intraoperative assessment. Because X-ray is very hard to give a decision. Often in the X-ray, you cannot see the cartilage part. So the real part is actually the cartilage shape rather than the bone shape. So actually, you need to do a proper exposure of the joint before you can properly do that.
Thank you.
Dr. PCO, I'm sorry, my video is disabled by the host. My question was for younger surgeons, what is your take on how do you basically assess the thumb which you want to choose to reconstruct? I mean, what are your clinical ways of assessing it to choose the best possible thumb, when especially a duplicated hypoplastic thumb, and where you want to put in all your energies to reconstruct it?
Your question is how to choose which thumb to preserve.
Yeah, which is the most functional thumb you would like to reconstruct, especially in a hypoplastic duplicated thumb?
Right.
And what's your clinical assessment which you would do preoperatively so that you decide what is the best thumb the child can have?
Yes, thank you. Excellent question. In fact, when I show my slide, the parameter, if I can show my my first slide, just let me show the first slide. It's easier to talk. Okay, this slide. Okay, so this is that when I assess both thumb, I will assess all these parameters. That means from the structural point of view, the size, the symmetry, the length, alignment, position, and then etc. The stability, mobility. Basically, I will remind myself to assess each of the thumb on this parameter. And then I will, of course, will decide which one to be retained. Usually must be the bigger thumb, bigger size to be retained. But when both thumb are small, hypoplastic, then you have to decide whether you combine or not. And whether you combine, then you have to decide what method you're using to combine. Is it the typical BOR correct, which is usually applied only for type 1 or at most type 2 extra thumb? But when you have a more proximal, the original BOR correct is not applicable. Then I think my concept using the island flap would be more appropriate. And then when you decide which to combine, which to reconstruct, again, it depending what is the deficient on your retained digit. If it's just the nail or the pulp is deficient, you combine with this nail head. Sometimes I show you, sometimes the ligament is also deficient. Then I will take the ligament graft from the reset digit to preserve it as an octograft to augment the deficient ligament on the retained digits. So once again, it's actually quite individualized on each digit, but the principle is the same. You basically follow this principle to assess systematically and stepwise. Then you probably won't miss any major element for your final assessment. So I think this is my opinion.
Thank you, sir. Thank you so much. I think we'll move on to the next talk by Dr. Shilu. Shilu is a very accomplished hand surgeon from Nepal, and we are glad to have you here, Dr. Shilu Shrestha. Please go ahead.
Thank you so much, sir. Let me see if I can share my screen first. Okay. First of all, I would like to start by thanking the organizing team for inviting me as one of the speakers. I feel very honored and privileged to be one of the speakers of this APFSSH pre-conference webinar series number 6, especially when my co-authors are big name in the field like Dr. Estrella and Dr. PCO. So post-traumatic reconstruction of hand is a very big topic, and I think it has a very long way to go. I'm just presenting my line of thinking I learned from my own cases. So the traumatic hand injuries is still very common, and it is because of the high velocity injuries. It constitutes complex tissue derangement, which includes multiple fractures, dislocations, vascular injury, nerve and tendon injury, and the skin loss. The very critical issue here would be it demands the involvement of the multiple specialty, which becomes one of the very challenging when we need all the specialty in the same space during a very necessary time frame. Otherwise, it will lead to stiffness, dysfunction, and disability. So when we get cases like this, I often wonder where do we start. But I think there are very great people in the history who has given this kind of a wise statement that we should start by thinking of the end. So I always think, what is my end goal in the functional reconstruction of this particular hand? So the basic goal would be always to restore the function of the hand as far as possible. And the function of the hand is to gain the information through sensation to accomplish the task. And it requires a basic hand, which is a stable wrist with radial digit with good sensation and mobility, and at least have 1 or 2 fingers on the ulnar aspect of the hand separated by a deep cleft. So the decision making depends on several factors like the age of the patient, which hand is involved, whether it's a dominant or the non-dominant hand, what does the patient do, and what is the expectation and the desire of the patient, and especially the surgeon's ability and the available resources. So I kind of divide the phases of reconstruction into 3 different phases. The early treatment encompasses the debridement, revascularization, and the repair, and then the osteosynthesis and the resurfacing of the wound, and late reconstruction. We might need the correction of the deformity, some tenolysis, or the recruitment of the new tissue components. So injury like that really demands urgent attention, where we need to do the microvascular repair of the vessels to put it back. And debridement is a very must. It means to excise all the devitalized tissue. So I always tell my patient that the wound is going to get bigger than the one you presented. So in hand, all the structures are in so much in superficial surface that any cut injury over the hand means 100% there is something cut underneath until unless we open it and prove it. So in this case, we can see all the tendons, nerves, and the vessels were cut. So we have to revascularize everything and repair in a way that it becomes functional. So then comes, after the revascularization, the bony reconstruction and the soft tissue reconstruction should be in a way that it can be mobilized as early as possible. So the osseous reconstruction can be done simply with a K-wire augmented with some interosseous wires, like in this case, or we can use the plates to fix the fracture.
For common one are Kessler, Adelaide, Cushion, and Lemensine.
So there are various repair technique, and we usually use the Adelaide technique. The order of the repair is debridement, exploration, bony reconstruction, tendon reconstruction, nerve repair, vascular repair, and the closure. So all this needs to be done before we do the formal closing and needs a very good rehabilitation. So after we do all the repair and the reconstruction, we need to close the wound. For a big wound like this, I still feel groin flap is one of the workhorse flap for me, which is very simple to learn. It's non-microsurgical, and it's very predictable, and it can cover a large wound. But we make sure that the patient start mobilizing after about a week, and we should make sure that the hand should be moving with the flap attached. But we can also have a free flap coverage, like in this case of lawn mower, we did a contralateral radial forearm free flap in this case. No matter what we do, the most important thing is we need to mobilize as early as possible so that we can get the function. So reconstruction of the hand doesn't mean that we need to have all 5 fingers. Sometimes when we get all the 5 fingers together, it just may become a nuisance if the finger is not moving. So in that case, we can sacrifice some fingers and use that spare part to reconstruct other fingers. So this is a case of a ring avulsion injury of the index finger, and the part was not available. But we can see after the debridement, the lady has a very good extensor and flexor intact. So we covered the wound with the tubular groin flap. Sometimes, like in this case, right thumb, it was not available and the patient was in ICU. So we debrided the wound, we deepened the first web space, and we used the iliac crest bone graft and covered with the groin flap. But I'm not a very good fan of this one because there are so many of my cases where there was a iliac crest bone graft get resolved. But sometimes the injury is so severe that there is nothing to really reconstruct. So in this case, amputation should not be considered as the failure of the effort, but rather a beginning of a well-planned surgery and a rehabilitation. So we spend all the time in the thumb and cover the rest of the hand with the groin flap and make a basic hand. So amputation proximal to the proximal interphalangeal joint, and when the part is not very good and amenable for replantation, rather than just doing stump closure, resection is a very good option for easy and faster rehab. Like this is a case of a 5 years follow-up of resection, and looking at that, you can see she is really a hard-working woman, and she presented with the injury of her long finger, which was already managed previously multiple times. So rather than spending multiple surgery to give her a very small range of motion, we offered her a resection, which is a single-stage surgery, very cheap, one-stage surgery. So, and then she goes back to function early on. Having said that, when there is amputation and there is through the middle phalanx and the FTS insertion is still intact, a good coverage over the end like this can make the finger very useful, which adds on the grip for the large object. So hand therapy and rehabilitation is utmost important for the early edema management and mobilization, and I feel very lucky to have a set of people who work very closely with me. So on late management, this is a case of a near amputation which was hanging only with the thread of some tendon. So after the fixation, we just use the K wire and we can see it's quite stiff and it is not useful. Then we can use the tenolysis and do the early range of motion. So sometimes even with the split thickness skin graft, we can see the level of contracture it can have. So we did the contracture release and did the radial forearm flap. So this would be my last case. So I just wanted to emphasize on when we get a upper limb injury like this, we are so concerned about the injury that we forget the systemic injuries. So this middle-aged man was injured with a conveyor belt and who had a very severe injury over the right upper extremity, but he also had the multiple refracture with the hemothorax. So once the patient was stabilized, we repaired the brachial artery and fixed the fracture with the external fixator and mobilized some muscles to cover the neurovascular bundle. And we decided not to repair the nerve at that moment and covered the wound with skin graft. And this is after 6 months, the fracture was healed, all the wound was healed with lots of contracture. So we did all the contracture release and also did the tendon transfer for radial nerve injury. And this is his function after around 2 years. And now he's very active in the society and seldom visit my clinic to inspire me. So to conclude, early immediate involvement by the primary sets the anatomy and creates a foundation for successful reconstruction. Reconstruction has to be tailored according to the need of the patient, remaining tissues, and the surgeon's ability. If there is significant deficiency, we should aim to recreate the basic hand. And it is very valuable to consider the use of the remaining tissue as a biology. In the complete amputation with no spare part, microvascular tissue transfer is an effective way to restore the basic function of the hand. Thank you.
Thank you, Dr. Shilu, for an excellent presentation. And the spare part surgeries and the amount of trauma you are acknowledging there is amazing, and the reconstructive work is excellent. So I want to ask you, have you used the primer toe transfer anytime practice for such if there is a loss of thumb and non-reconstructible thumb? Have you used a primary toe transfer? Do you explain the patient that this might be needed pre-surgery?
Yes, definitely. I have been very fortunate to have a very good set of mentors. So whenever my mentors would visit, I would jot down the date and also the phone number of the patient, and I have a list of patients which I want to do it when my mentors visit here in my country.
Okay. Thank you. Any question, Dr. Anil Bhat?
Nothing from my side. Any other questions from the panel itself here? Bipin, you're there?
Yeah, I'm there, sir. So there is a question from one delegate on my WhatsApp. So he's asking Dr. Emmanuel.
Your voice is breaking, Bipin. You can switch off the video, I guess.
Yeah, you can hear me now?
Yeah.
So Dr. Emmanuel, he's there. So there's a question for Dr. Emmanuel.
He's there.
Yes.
So there is a question for Dr. Emmanuel that so what is do you go for second tenolysis after hemihamate?
Okay. So from the cases, I haven't done any form of tenolysis yet. I think the key there is early range of motion, because the procedure itself is a stable procedure. Once done adequately, the early motion can be instituted as early as a week after. I think the key there is the stiffness. No, so as early as a week, as long as if the patient cannot tolerate the pain, I think some form of analgesia during PT sessions will encourage the gliding of the tendon. That's why I think because the stability of the fixation will lessen the chance of any tendon adhesions. So no, I haven't performed yet any tenolysis for the cases.
And any experience with volar plate arthroplasties with compared to hemihamate arthroplasty?
I've had some cases of volar plate arthroplasties, but I think the decision making lies in that the fragment should be big enough. No? It should the fragment remaining, the dorsal articulating surface. I think if it's more than 40%, but I think the decision making lies that good results. I think it's best for 30% or less, no, if the fragment cannot be fixed primarily with a screw or with a plate, a mini plate. So I think the key decision there is that the articulating surface should be at least should be less than 40%, 30% at best.
Thank you very much.
I think we are running a little late, so I think we'll close the session. And this series is basically to get perspectives across the Asia Pacific and all the practices across these countries before we meet in September. But I can always say that principles always remain the same, whichever country you are in. The methods might change, the skills might change, and the way you approach might change. But at the end of the day, I think all of us work towards a common goal of the principles being to be very true to our principles and make sure that the patient gets the best out of all these procedures. I think that's what I saw in all three of you. I really thank you for your valuable time, for spending time with us on this webinar. Thank you, Dr. PCO, Dr. Emmanuel, Dr. Shilu. And it's always good to see you all back, and hope to see you all soon in September in Mumbai. Right. Thank you, everyone. Thank you all the delegates for joining us. Have a great evening. Thank you.
Thank you very much, Dr. Bhat. Thank you.
Thank you.
Thanks, Bipin. Thanks,
you,
Nilesh.
Shilu.
Yeah.
Thank you.
And
Yeah.
Shweta
Shall
from
I
Medic
conclude
2.
this
Thanks.
session, sir, now?
Please do. Please go ahead. Thank you.
Thank you.
Thank you, sir. On behalf of VDOP2, I would like to extend our heartfelt gratitude to all the speakers for their insightful speech and the moderators for their extraordinary moderation. A special thanks to Dr. Nilesh sir for coordinating this session. I also thank all the delegates for joining today. So with your permission, may I end the session?
Please
Yes.
go ahead.
Yes, please.
Recording stopped.